So now let me invite the panelists to come to the table. And Kathy Kim from UC Davis will be moderating this panel, which has several of our colleagues as well as patient representatives. And I'll ask Kathy to introduce them all while we are still following our poll in the background.
Which one?
Oh, no, that's our notes.
Okay.
Yeah. Well, welcome, and thank you. While everyone's coming up here, I'm just going to spend a quick minute to introduce everybody. We have some a very brief comments that each person on the panel is going to speak to, just 2 or 3 minutes each, and then we have some, we think, controversial questions to ask of the panelists, where we also want to invite you to weigh in on these questions, and then a little bit of time for you to ask additional questions. So we have 5 panelists today. So Alma Daneshi is a patient. She's a brain injury survivor as well as a 3-time cancer survivor. She's a member of the Cancer Care Access Partnership and founder of Vamos a Charlar, which is a Spanish cancer support group in Southeast San Diego. Our second panelist is Rebeca Espinoza Jacinto, who is a PhD candidate in global health at UC San Diego and San Diego State University. We have Lisa Madlensky, who is a genetic counselor and director of the Family Cancer Genetics Program at the Moores Cancer Center. Richard Schwab, who is an associate clinical professor of medicine and director or co-director of the Moores Cancer Center Biorepository at UC San Diego. And then Kristen Wells, who's a clinical psychologist and an assistant professor in the Department of Psychology at San Diego State, and she also participates at the Moores Cancer Center. So I'm going to kick it off with Kristen.
Right. So I think
Is it on? It's on.
it's on. Just get close. Okay. I think we hope to have this to be a very interactive panel with the audience talking to us. It's not just us talking up here. So we actually, instead of you guys asking us questions, we're going to ask you a few questions first. One of the things that the research that I do looks at whether people understand to be able to provide informed consent to participate in research involving biospecimen donation and biobanking. And one of the things that we often ask people is, what is a biospecimen? Just to see what people say. And so we wanted to pose to you all first how you would answer that question. If somebody were to come to ask you, well, what is a biospecimen? What would you tell them?
You could have one person per table be the spokesperson.
And then there was silence.
We can just call on people or tables. No.
Well, goodness, I'll say something. No, you're wrong. A biospecimen, here we go. A biospecimen version 1.0 is a sample of your, let's see, in plain language, a sample of your body or secretion that can provide useful information.
Anyone else?
There you go.
I would add that I agree with that, and I might add that's suitable for a genetic analysis.
It doesn't have to be. I mean, it can be.
Well, that seems to be the intent of what people are getting for. Most likely.
We don't do DNA analysis on urine samples, but it's a biospecimen. We collect all kinds of things on patients. We collect spit, we collect tears, we collect urine, we collect skin biopsies, tissue infection. Those are all biopsies, but not necessarily.
Anyone else? So 2 answers. Go ahead.
So from the ID world, it's always talking about the microbiome. It doesn't even have to be your own necessarily genome. talking about your microbiome of your gut, for example, would be an identifiable thing. So is it considering that as a biosample as well?
Okay. Is there a fourth? I think that this is a good example about how difficult it is to explain this to the general public. When we're asking them, will you be willing to donate your biospecimen for research? It's not an easy concept to explain to people. I've designed some surveys to evaluate what people know about biospecimen donation and biobanking, and this took forever. This part about trying to come up with a definition for biospecimen and for biobanking, it took us quite some time to work through this, to be able to explain it in a way that used words that were not too scientific for people to be able to understand. We came up with biospecimens are materials from the body, like blood, urine, skin, or saliva, that a person can donate for science. What do you guys think? Do we do okay?
One came in through the chat window. It's very similar to what you just said.
Okay.
Part of your body that can be used for health information, such as tissue, blood, urine, or sputum.
Okay. So yeah, being able to communicate what a biospecimen is, it's almost like the foundation for being able to start talking about informed consent, talking about exactly what these things mean.
Thank you. And we want to ask Alma to talk about her experience because she's been asked to give informed consent for these things, and she's also worked with many other patients that have gone through the process, to tell us a little bit about her experience.
I'm a 3-time cancer survivor, so I've been in and out of doctors' offices for many years. And also, I'm a brain injury survivor, and I had to learn how to walk and talk all over again. So when I had to sign papers, I really wasn't understanding what I was filling out. And being in the community, I have other cancer patients that are also going through the same thing. When we are given the form, some of them don't have the knowledge of the English language, and vice versa. The doctor doesn't speak Spanish, and the patient doesn't speak English. So right there's that barrier. That's it?
Yeah. Well, we want to turn to Richard to tell us a little bit about, when do you get informed consent for biospecimens? How does this typically work in institutions?
Yeah, it's hard for me to address sort of typical because there's lots of different arrangements. I'm an oncologist, and I run the cancer center's biorepository co-directed. So for cancer patients, it's quite different. Cancer patients are obviously unique in that, in general, they'll have surgery where a portion of their cancer is removed, and that sample is very important for research. Typically, surgery is done up front, so most patients who are going to have surgery for cancer tend to have it early in their treatment. So that means approaching patients very early after their diagnosis, so it's a very challenging time to approach someone. And I don't think there's any simple way to do it. What we've found is that, similar to what Elena Martinez was talking about, is that really engaging the surgeon is the key, because the patients at that point tend to identify, frequently the surgeon is the one and only person who's talking to them about their cancer diagnosis and telling them how they're going to be treated. So having a surgeon explain why collection of samples is so important for research and really engage them so that it's not just a researcher coming up and approaching them, but rather really engage them in understanding why it's so important for everyone's benefit to have these samples collected, and how much goes into the process of safely doing those collections. Having that physician involvement has been key. And in our experience, if we don't have the surgeon involved, we just attempt to have a researcher contact the patient more or less directly. Obviously, it can't be without assent, but we can gain assent for contact even with lesser, with a medical assistant or with a nurse. But if it's not the physician who's directly involved in that process, it tends to not be very successful. You could imagine in other aspects of care and and specimen collection, it might not be as sensitive, but for cancer patients, it's a little bit unique.
So we're going to ask Lisa next to talk about her work, and if you could mention maybe some of the differences between being asked to contribute a biospecimen versus the issues involved in genetic testing, for example.
Sure. And there's a surprising amount of overlap, but a surprising amount of, maybe not so surprising, quite a few differences as well. So when we see patients in genetic counseling clinic, we often have the luxury of having our consultation really essentially be not only an assessment and we're doing our consultation, but really the whole process is an informed consent process. We really end up walking the patient through what are the potential benefits of genetic testing, either for themselves, for their family members. We talk about the limitations of genetic testing. So unlike a lot of the marketing materials that are out there implying that you will empower yourself and learn everything you need to know, there's no such thing as a perfect genetic test. There are a lot of limitations. And so we really want to make sure patients have a clear understanding as much as possible in terms of expectations. What's the likelihood we're going to get something informative back from this genetic test? We then get into other layers of information, though. That's kind of the most straightforward situation. We get into other layers of information that relate to biospecimens and consenting. So, for example, now most of the commercial labs, if you're getting genetic testing, allow you to opt in or opt out to have the lab continue to use your sample for research, and I'll use the air quotes for that, once the testing is completed. So that may just be that they use it for quality assurance in the lab. It may be that they actually use the DNA to design better tests. But it's now a commercial entity that has that specimen, and so there's that layer of consent that gets involved. And then the other thing is, even though we see patients as part of a clinical service and we take referrals, do consultations, give information back to the referring physician, we also are very much involved in a lot of genetic and genomic research projects. And where things are getting very interesting right now is the whole idea of incidental findings or secondary findings. So let's say you're doing a research study, like Dr. Komaneka and Dr. Martinez on breast cancer, but maybe we've done some genomic studies and we've found that there are a subset of people who have a genetic predisposition to early onset heart attacks that could be very important for them. Are we obligated to give that information back? Are we de-identified? Can we break the code? So all of these issues are fairly new issues as we've been able to do more genetic testing cheaply and really look at the whole genome as opposed to just targeted areas of the genome. So this is an area where I'm starting to get calls now from physicians and researchers who are doing projects saying, we were doing a project on X, but we found something about Y. Can you help us tell the family, or how do we do this? We don't even know where this patient lives anymore. So there's a lot of complexity that goes on, and I'll just say it's a very interesting time. I'll end on that note.
And finally, we'll just have a comment from Rebecca. Alma mentioned, the challenges for patients who don't speak English, who are maybe with clinicians or researchers who don't speak their language. Can you talk about your work in that area and maybe mention some promising practices for both non-English speaking patients as well as low literacy patients?
Yes, definitely. And Dr. Talavera sort of went over this a little bit prior to this, as you remember, and really talking about making sure you have culturally aligned staff, so not just bilingual, but also bicultural. He also mentioned working in the community, so not just coming in and coming out, but really being part of the community to provide dissemination after you do the data collection and analyze the results, really giving back to the community and have that dissemination process. You had mentioned doing sort of like a fact sheet or something for participants, and this was very difficult for us as well, especially when it comes to translation into Spanish. So again, it was doubly hard to make sure that this was understandable, that we explained it in a manner that was accessible to different literacy levels, English and Spanish, but also doing it in both languages. So we also wanted to make this like an interactive question where we sort of ask each table to provide something that's really worked for you as researchers that can probably benefit everybody else as far as making sure that you do communicate with your population of interest and how you do that. ask for some questions.
Yeah.
Maybe
so-
one person per table can be the spokesperson or.
You have promising practices that you've used or have heard about.
Just start calling people. Are you shy people? One person over there, I think.
Sorry, I wasn't sure if you wanted table discussion first, but it sounds like you're just wanting to hear from the table. So before I worked at Picori, I worked for a research institute, and we developed something called the Readability Toolkit, which is designed for making research more readable and understandable. It's a freely available toolkit called PRISM. If you Google PRISM readability, it should pop up. It's open to anybody who would like to use it, and it's geared
great.
toward
Wow.
rewriting informed consent forms, HIPAA, and it's all been vetted by IRBs, and typically comes in around 8th grade reading level. So
That's wonderful.
PRISM Readability Toolkit.
One person. They're still discussing. Shy tables today.
Any other thoughts you want to share right now? Okay, well, you can continue to think about it and add it at any time in the next interactive part of our panel. But we want to pose this question. So we know that the consent rate for contribution of biospecimens is already very high. So people really do consent for this. If that's already high, why should we educate patients anymore? What if the education or the information actually makes them think twice and they actually consent less? What's your response to that? We'll take responses from the panel and from the audience. Go in the back.
So I would argue that if we educate our potential subjects correctly, it would not harm their interest in consenting. As a stakeholder and a representative of stakeholders who really need these samples to do research, I will tell you that there will be resistance to changing the way we do educational processes because of that concern. So anyone who's interested in changing the way the education is done would be well advised to test that and make sure that it doesn't harm consent rates. I think the speakers today have done a very good job of pointing out that this is a rapidly moving target. And in many ways, I think some of what we're dealing with today, although right now it seems to be more and more of a problem and a challenge, I think in the future it may actually go away in some way. And I was just thinking about it listening to the talks today, that we're constantly shedding our DNA all over the place. Basically everywhere we go, we're leaving our DNA behind. So in 10 or 20 years, really anyone who wants your sequence will be able to get it. And maybe it'll be a moot point, and they'll all kind of look back at this time and sort of laugh that we were so worried about protecting our genetic identity, when in fact we spread our genetic identity everywhere we go every day. But at least for now, it's something that we have to educate our patients about, or our potential subjects about, so that we can do this research. And what I worry about, the threshold that I use and many of my colleagues have used, is the front of the newspaper criteria, right? We don't want to be on the front of the newspaper, and that's not tomorrow or even next year, or even in 10 years, we don't want to be in the front of the newspaper for having done something where we will be looked back upon it as having done something wrong, because it's not always entirely clear where right and wrong lie, and the laws and regulations are horribly out of date and really do almost nothing to address this issue. Just as an example, as I go off on a tangent, I apologize. As an example, when you're dead, you're not a human subject anymore. So in the past, autopsy specimens were used for research as the family member just on the clinical consent checked off okay for research. Well, does that mean that we can do germline sequencing on that person and post their sequence in dbGaP? I think the answer is no, and it's because of the newspaper criteria, which is someone's going to sequence themselves and find out that their family member was sequenced without anyone's knowledge and posted on dbGaP. It's fairly trivial to go back and do that. So I think it's a rapidly moving target. There's lots of scary things happening, but in the future it may actually end up being a moot point.
So to follow Richard, So coming from the presentation that I just gave, where in Ian's clinic the consent rate is so high, I do worry about what the women understand about the consent. Are they just saying yes to Ian and to whoever comes across them at Maricopa? And what do they understand, really understand? Do they know what a biospecimen is? Do they know what's going to be, do we know what we're going to do with it when we don't even know what we're going to do with it? And at the end of the day, I think what we all want in our community is a patient who is informed. I mean, that is the informed consent. So if that patient is not informed, are they giving you consent? And I come at this because one time a group of us wanted to do a study in a clinical trial setting in Latin America to assess what the participants understood about the informed consent process. And the principal investigator of that clinical trial told us he would not allow us to do that because he didn't want to end up in the newspaper like that. It was one of these big cooperative groups that I won't name, and it was being done under the auspices of that NCI-funded cooperative group. And he said, I will not allow it. I will not allow you to go and try to assess what these patients understood. And I was coming at it from, we need to understand so we can do a better job at educating them and helping our informed consent process so we can continue to improve that. But he would not allow us to do that. So this is another long-winded answer following on Richard, but it's such a moving target, and for underserved populations, you know, even more behind. And how do we catch up, and what do we do? And are we all targeting 100% consent? No, it's more on the informed patient, and where do we get there? How do we get there?
I think I am a researcher, and I do research, do consent the
Can you hold a little closer?
participant in a regular basis. So I think I very much like our participants join the study, like because we already have like the baseline data, phase 1, 2, 3, and phase 6. I really want them to be in, but at the same time, I really want them to be informed what we are doing, as much as I can understand why we will use it and how we will use it. But something beyond my understanding, I don't know, but at least from my point of view, I want them to understand what we are going to do with their biosample, and they are truly informed, and so that we establish that trust in with our participants. So because research is really a ongoing process, we don't want like ruin that trust for just a short time, but we want it to establish that trust so that in the future we can do more research.
And there was in the back as
Yeah,
well.
thanks. I think one of the challenges we have nationally is that we have all these biobanks growing in various different regions, and the way that we're handling consent processes are totally different. There's initiatives for funding out there coming up right now, right, to get us to do that better. But one of the big challenges, I think, right now is that we can do anonymized consent for biobanking, but we don't necessarily have the ability to connect that to the phenotype data. And so when you ask the question, do we need to continue educating patients, I'd say yes, because we're on the verge now of trying to really figure out how to smartly link in all these big electronic health data phenotyping databases with the actual tissue banks, which is going to, be very powerful for research, but also have a lot of privacy issues for patients.
And in the corner back there.
I think it's one of the things we've talked about was the idea of the total amount of risk and how a general consent carries perhaps more risk than a specific consent. So this idea of not only asking people for consent, but also governance of how it's handled after the consent is obtained, and the amount to which patients or people who give the consent have some ability to govern the future use of that, I think is an important question. And obviously maybe not on a per person basis, but representatives or advocates or speakers for different populations have some voice in governance of how those samples are used is something we need to consider.
And there's another comment in the chat. that concurs with what people have been saying, that the goal is to have participants be fully informed. And although we as researchers often view the participation as a primary outcome, it should be considered a secondary outcome.
Yeah, one point I wanted to make is typically you actually get a pretty consistent number of people willing to participate, and that's 95%. Generally, if you ask people in a very general sense, are you willing to donate a specimen for research? You get about 95% who'll say, sure, if it helps research, helps us understand disease, this is a good thing. And so I suspect that even if there was variability in the amount, you could spend 2 hours with someone, you could spend 5 minutes with someone, your chances are you're probably still going to get close to that 95%, I suspect. I wanted to follow up on a couple of the comments that were made too. And there's some guidance that's come out recently from some of the consortia that are doing large-scale genomic research studies, and some of them are linked with the eMERGE consortium as well. And the guidance that came out had a very, I thought, sensible title, which was sort of the floor, the ceiling, and everything in between. And it made the point that there's sort of a floor of ethical conduct if you're going to be doing large-scale genomic sequencing on a research basis, where if you find something that the term we use all the time is actionable, would this change your medical care in some way, or would this be important for you to know for your health care? Not, kind of what eye color do we predict you have, but something that would actually change your medical management. So if we find something actionable and there exists a way to link it back to an individual, that there is an ethical obligation to try to do that as best you can. The ceiling is really basically laying it all out there and saying, we're going to sequence everything, we're going to find everything out about you, and here's how we're going to give that back to you. You can opt in, you can opt out, there's a whole menu of choices. And it also recognizes an important point, though, which is that researchers are under no duty to hunt. So basically, if you're doing a research study on Alzheimer's disease, you have no obligation to go and find BRCA mutations for breast cancer risk. And that's a really important point, because we don't want researchers feeling overwhelmed with this idea that they have this information at their fingertips, and are they ethically obligated to go looking at something that has nothing to do with their original project. So it gives that reassurance and guidance to researchers to say, we understand that budgets don't allow for this. We understand that you don't have, the certification to issue a report that can go back to a physician and go in a medical record. These are usually grad students, lab assistants that are, doing the best they can with interpreting what comes out of this information. So there is some emerging guidance coming out of all of this, but at the end of the day, it all falls back to that consent process and setting expectations accurately. A lot of times people think that even if they've been told for 2 hours, this is for research, this is only for research, this is not a medical test, but they have my blood, they're going to tell me something. And so I think one of the biggest pieces of education is really helping patients and research subjects and participants understand that there should never be an assumption that you will ever hear back from this ever again. And that's how I actually put it to my patients when they're participating in research. Don't have any expectation you'll ever hear anything. There's a remote possibility you could, but you should never expect it. And any testing that needs to be done as part of your medical care, you need to talk to your medical team about that. Do not assume that a research study is going to answer that question for you.
I would say that in general, there's a wide chasm between what we know about biospecimen research and kind of what the general public thinks is true. I've actually done a little research on this topic. We asked people in the development of some surveys whether they thought something was true, false, or they didn't know. And one of the questions was, researchers will always contact people if their biospecimens show risk for disease. Only 16% of people said no to that. So that means that 84% weren't sure, or they thought, yes, in fact, they will call me. They're waiting by the phone for you guys to call. So they also believe that the police can get access to the biospecimens, or they don't know. They think they could be cloned, which is interesting because they're very willing to donate. But it's there's a wide gap between kind of what is believed and what the beliefs that we have.
So I want to ask a question about, what happens to your biospecimen? I love that you said you're shedding your DNA everywhere. So all the crime shows where the suspect blows their nose and puts the tissue in there, and then they get their DNA and they match, right? Well, if your DNA is everywhere, why would you be concerned about the fact that you gave a specimen for research? What do patients think might happen to those specimens? What would they worry about would happen to those specimens? Alma, were you ever concerned about what happened to any specimens you gave?
Yes, I was concerned about it, but the answer that I got was, "Oh, well, we don't know about that yet, or you'll have to make another appointment, and I'll explain it to you." And I get a lot of women saying the same thing, that their healthcare professional doesn't give them a lot of time to answer their questions, when in fact they want the paper signed, their consent signed, their authorization on their signature on the paper, but yet they don't want to really explain because they have to go to the next patient.
Is there a comment?
2 comments and a question. So the first comment is that a more educated lay community could help provide better insights for researchers to perform better research. And the other suggestion is that there are a lot of smart non-researchers with passion about health issues and unique perspectives, worldviews, and principles of investigation in other domains that we can learn a lot from. And then the question is, how many people include a checkbox in the consent form that allows a participant to confirm or pass on being informed of additional unintended information that may arise from studying their specimens?
Oh, that's a good one.
So we had thought about including a checkbox for that, and actually at one point our IRB requested that we include such a checkbox. It was actually not on our main biorepository, but on a similar study. And the bottom line is that I didn't think that it was ethical to have that checkbox, because I don't know how I would go about educating someone about the risk of declining to hear about a future result when I don't know what that future result might be. So if we discover something new that's 100% penetrant and easily preventable and actionable, I don't think that the participant would have chosen to have opted out of receiving that information. And I would not have educated them about that possibility. And if I include a checkbox where they can opt out for future return of incidental actionable findings, I've now boxed myself into a corner where I've asked them to tell me what they want me to do based upon something I don't know what it is. I now put myself in a corner where they're about to step in front of the bus, they're blind, and I'm not allowed to grab them. So I decided that I wouldn't accept a protocol which had that restriction on it. Rather, the language is, if someone wants to participate in our biorepository, they must agree to hear back from us or their provider on those rare occasions when actionable findings occur. They do not receive the result. The result can be used for clinical testing and to direct clinical testing. And before that clinical testing would be done, their informed consent for that clinical testing will be obtained, typically by Dr. Madlensky.
Yes, question here.
So we've been collecting DNA on patients in our population for about 10 years. And initially,
it's on.
Is that on? Okay. Initially, we didn't have that box where you could check, yes, I want to hear, or no, I don't want to hear. And we ended up using a genotyping platform where we found out about the factor V Leiden mutation in a couple of patients. And we weren't sure what to do. So even though I'm the chair of the pediatric IRB, I didn't know what to do. So we talked to some people, we talked to some bioethicists, and everybody agreed that this was in the mother of one of our patients who was of childbearing age and might well want to be on birth control pills. So we decided there were plenty of reasons why this was an actionable health risk for this individual. So we called the family and let them know that if they wanted to, they could pursue genetic testing formal genetic testing for this mutation. And it was the
advice of the bioethicists that we talked to add those boxes to the consent form. So this was about 10 years ago. And initially, we had a few people who would check the box, say, no, I don't want to know anything about my DNA. And more recently, no one has ever checked that, and we've enrolled about 3,000 people. So I think what's happening is that there's a change in the ambient understanding of genetics and fear of your genes, and what that is or what that might mean has dissipated. And so people are perfectly happy. But we're actually going to take the move that you're taking now. We're going to take away those boxes and just tell them that they're going to hear about it if we find something they think is in their best interest. But anyway, that was the evolution over 10 years of our being involved in genetics research.
And we're just about to end up, and I think we have time for one more question. So if there's a burning question from the audience that you want to ask the panel.
I think that this kind of builds on a couple of the points that were made. Who does the telling? I think we have a huge problem with coordination of care. I think when you get out of academic medical centers and into community physician settings, do the providers have the requisite knowledge to be able to follow the field and recontact their patients? This just is a big root ball, and every comment seems to make it more rather than less complicated. So it's just more of a comment than a question. If anybody has any thoughts on how to sort of bridge that other gap to other physicians and providers, I should say clinicians and providers, that would be great to hear.
So in very general terms, it is a challenge. Even with what I would consider to be routine genetic testing, one gene predicting one disease or making a diagnosis, the amount of errors that happen in ordering those tests is quite astonishing. One of the things that a lot of the labs that market the tests are quick to say is, there's a shortage of genetic counselors, and so, we need more doctors ordering more tests. The truth is somewhere in between, I think, where, the idea of incidental findings found on a research setting may come out of nowhere, may be completely unexpected, or it may be something that you get the information, say, of course, Mr. Smith has this mutation. We should have guessed that. Or in fact, we've already done testing and we know about this already. That would be the ideal situation, is that there are no surprises. But there will be surprises, and part of the role of the genetic counseling workforce is we see patients, we order testing, we coordinate all of this. But we're also very, very, very keen on physician education and helping those providers out in the community that don't necessarily have an academic medical center or genetic counselor working right with them. We're very, very keen on helping those community doctors get it done right and providing the backup for those rare times when something unexpected or unusual really does happen. So there's a long way to go. I think there's room for improvement with physician and provider education. Someone mentioned, I think on the chat, a more educated workforce. Genetics education is abysmal. People have no idea that, half their DNA comes from mom and half comes from dad. There's all kinds of myths out there. So that to me is kind of the most basic stepping stone, is helping that young, cohort of kids learn about science, biology, how our bodies work, what our cells do, and then maybe we'll get to the physicians. I don't know, Richard.
Well, let me close by saying I think I'm poorly educated on genetics, even though I was a biology major. But I joined 23andMe, and I'm apparently Asian. I learned that. So join me in thanking the panelists for a wonderful discussion.
Thank you all. I guess you see the privilege of working with some of these people and the previous speakers, because there are a lot of interesting things. I just wanted to also say why I decided to put this panel here, since we're in the DING meeting, data sharing, and not on the BING meeting, which would be the biosample, because the samples without the data on the phenotypes mean absolutely nothing. So would people consent to 90% or 99% of their data being shared, the clinical data, longitudinal, so that you know that that sample was collected at a certain time, but the disease did develop 20 years from them, which is what the cohort studies are doing. So I thought it was very pertinent because as we collect data, we also want to collect future data, which will stem from this biosamples.